So first for Kim, actually, about the HER2 heterogeneity. Could you, do you know of any study that have found any association between, patients that have heterogeneity versus not using these guidelines that have been defined? And how much is this independent of ER positivity, which, ER positive, HER2 positive tumors already known to be more resistant. So if you could just start the discussion with that, and then we have the questions. Yeah.
Yeah, so as I mentioned, a lot of the cases that had heterogeneity by that definition of 5 to 50% amplified cells end up in that equivocal range, the close to the threshold for positive. And we recently just looked at, because these cases are rare, so there aren't a lot of studies looking at the 2 to 5% of cases that are equivocal or close to the threshold for positive. We just pulled together data from UCSF, University of Washington, and here, looking at those cases, and the ones that are in that close threshold do tend to be ER positive. They tend to be grade 2 to 3, and not a lot of grade 1 cancers. So they're in the hormone receptor positive cancers. There's more heterogeneity. They're more close to that threshold for positive. Okay.
So just taking this to the next level, Kim, shouldn't we be reporting HER2 testing in exactly the way that you showed it, by basically your cell populations as defined by HER2 signaling? So I mean, when Edith looked at N9831, when we looked in HERA, we showed the trastuzumab benefit was independent of the ratio and also centromeric 17 number. So the HER2 copy number per cell is everything.
Right.
And we know you've got the clonal drift with time. We've just shown that 26% of the tumors in livers go from HER2 negative to HER2 positive when they go from adjuvant to metastatic. So if you did your HER2 cell populations as less than 2, 2 to 4, 4 to 6, however in that area, you can just watch the drift as you go through treatments.
Right, and I completely agree with you that signals per cell is really what you want to be looking at in measuring the cell populations. Yeah. And otherwise, we're kind of artifactually correcting for things.
Yes, Carlo?
I think this is for Christina. But I like the Big Bang result, and it fits the data really well. There's 2 points there. One is there's 2 regimes we're talking about. There's the carcinogenesis regime, where there may be clonal expansions, but what you're talking about is once you get the transformation, it's that second regime of the malignancy that you see that. But what I'm wondering about is whether the data you see, you can distinguish between cell migration mixing up the clones, or versus the Big Bang all just spreading from the center but staying next to all their neighbors.
Sure, no, great question. Yes, so precisely we are referring to after the initial tumor initiation. And with respect to the mixing, so I mean, basically what we're finding is that these patterns must occur very early, and we can simulate the processes, and we find that actually if we go above 8 glands, that a private mutation will no longer become variegated in the population. So we're really talking about an early time point where this spatial kind of structure matters, as Nina also pointed out, that it happens quite early. So we think that it could be due to loss of cell adhesion. Of course, we're simulating fairly rudimentary processes because we need the information from these studies to feed into those models. But clearly, it seems to be at least robust to microenvironment. So I hope that answers. Yeah.
My question is for Dr. Ellison. I wanted to know how truncated version of HER2 receptor and the estrogen receptor variant come into clinical settings, and how do you diagnose, do you take that into consideration?
Truncated versions of
HER2, yeah.
Dr. Pegram maybe should take this question. Well, currently that isn't something that we're testing for. We're looking at protein expression and the gene amplification clinically, but there are folks who are looking at that and attempting to bring that to clinical practice.
Right.
Clinical trials open. Not yet, almost.
And then there are estrogen receptor variant also recently diagnosed, right? So do you think that would make a change? Estrogen receptor variant, there is a shorter dwarf version of estrogen receptor called ER alpha 36. So it lacks AF1 domain. So it depends on which kind of antibody you use against C-terminal versus N-terminal. So that can also mislead, like you classically call it negative, might not be ER negative. They might be ER alpha 36 positive. So do you think that this will affect the field tremendously, and how we actually classify ER positive, HER2 positive versus TNBCs?
Yeah, I mean, I think the real question is what will clinically happen to those patients if you treat them
Right.
with hormone-targeted therapies? So,
Right.
are they going to respond in the same way? And if so, then we need to be detecting them.
Right,
We know that some PR positive, there are very few PR positive, ER negative cancers out there. They don't tend to respond as well to hormone-targeted therapy. So it depends on multiple factors. But yeah, you're right. The antibody choice will make a difference.
Right. And this could serve as a resistance prognosis marker, right? Whether the patient will likely to get benefit or not, or how to give the treatment or design novel target to inhibit such variants, right?
Potentially, yeah. I mean, if you can show that there's a difference in treatment response based on.
Thank you.
Yeah, that one question.
So, hate to pick on you, Kim, but two questions. I don't understand the mechanism of anti-estrogens if I get a response where only 1 to 10% of my cells have the marker, 90% don't. So why am I getting a 70% response rate?
Well, yeah, I think that's a great question for HER2 as well as
Right.
ER. And, tomorrow we'll be talking about immune response. There are many reasons. We talked about the rest of the environment. Yeah, that once you kill certain cells, maybe you're generating an immune response to all of the cells by exposing new antigens.
But do we have evidence for that? I mean, I've looked, and I'm always confused of why it works. Same thing with the HER2. If you have the same number of stained cells in your specimen, but some are in clusters and some are isolated, which ones respond better? Which tumors respond better?
That we do not know. Yeah.
Yeah. I mean, the other thing, but we don't know, if I can comment on this, because we don't know if an ER-negative cell is ER-negative forever or just at the time when we're measuring. Because I think proliferation can influence some of these markers, and that's something I keep asking people. Does ER change when you proliferate, in G1 or S phase or something? So could there be that we actually miscalling those cells? Or the other possibility is that you do have a subset, which is ER positive, and that's kind of the driver clone, and the
Right.
rest of it can be just feeding on it.
So if you look in the handout, the brochure, and the pictures we drew, we have a fifth type of intratumoral heterogeneity, temporal. So these things change with time,
Yeah.
even if you don't treat.
Yeah, that's why I was suggesting that we're missing the in vivo, imaging following the heterogeneity part. Somebody has to develop a technique. Yes.
Hi, thank you for all the amazing talks. My question is for both for Dr. Curtis and Dr. Bissell, actually. Are there any studies or any ways in which we can study the genes or epigenetic changes or downstream changes associated with quorum sensing, for example? I mean,
Associated with
quorum sensing, because quorum sensing is studied more in
Yes,
bacteria
yes.
in smaller forms, but I haven't seen much. I mean,
well, we have
you
we have a little bit of data actually that we haven't yet developed the way I would like to, in that there are pathways that determine shape, and there are pathways that actually are involved in how cells come together or don't come together. And I have helped organize a Keck Foundation NAS meeting in 2 weeks where we talk about going from single cells to and with quorum sensing, and about what is it that happens when you go from an individual to a lot of things, like how do the bees do it, or how do how do the cells do it. So maybe after that I'll be more be able to answer that. But once we develop that, I'll be very happy to share it with you. Yeah.
Thank you.
I would just comment that I think, this issue of, in a way, clonal cooperativity also comes to mind when we think about this. And I think certainly, many groups, and Nellie talked about this as well, are developing approaches to begin to assay that. I mean, it's non-trivial, and I think it's certainly the way to go, because what none of us mentioned that certainly should have come across is that there is obviously phenotypic convergence of many of these traits, right? And so understanding how these different genetic signatures are converging on that is really critical, and I think that those are sort of outstanding questions, and I guess maybe Carla will talk a little bit about ecological, now you don't have time, approaches for it. Yeah.
Thank you so much.
Yes.
Hi, I'm Ginny Kang from UC Berkeley. This is a really interesting section. I have a question specific for Dr. Wiesel. So what do you think about microenvironment change during, like, what people say the clonal evolutions, like, for certain patients, and how do you think about, like, what will be the optimal therapies for, yeah.
Wait, this requires a lot of stuff, but I'll be very short. I clearly would think that everything changes all the time. They are dynamic. They are so dynamic. Depending on what you eat, your tumor is going to behave differently. I am certain. So I think things are going to change. But then the question of how do we actually treat the microenvironment is another thing. I wrote a review with Kurt Heinz in Nature Medicine 2 years ago, and the title is "Why Don't We Get More Cancer?" rather than everybody says, "Why do we have so many cancer?" So in that review, we have table after table after table of the possible drugs or the kind of drugs a lot of people are using that to treat the microenvironment. And I just wish that the companies will find a way of finding aspirin or a Motrin or something that wouldn't be so inflammatory, to cause bleeding. And if we had that, that would be a big treatment of the microenvironment, because it would calm down inflammation, it would calm down fibrosis, it would calm down a whole lot of other things that would change the microenvironment in terms of the signaling back and forth. One other thing we haven't talked about in this meeting at all is the role of immune system. Not the good immune system, but the bad immune system. The macrophages and the different kind of these cells have such an important role to play. So we have to understand the immune system in terms of that division between those that push the tumor and those that don't. And if I may be allowed just one little side comment, I'd like to bring out to people's attention that there are many experiments of this kind out there that people ought to be aware of. And one of them that I really like is Gerard Evans. Gerard Evans is a guy who would get up after each talk I gave and would say, Mina, MYC is an absolute single oncogene, and it does everything. And I would listen, so one time he made a model of pancreatic cancer using MYC. And it was a very wonderful model. And then he had a postdoc who listened to somebody, including me, who said, look at your data, look at your cells. So she went and looked at these tissues, and they were full of mast cells around the so-called tumor. And she said, ooh, maybe they're playing a role. So she inhibited the mast cells. And here is a transgenic animal. Every cell has MYC, and it's activated or does whatever. No tumors. No tumors. And then they went back to a mouse that didn't have mast cells, and then they didn't have any tumors whatsoever. So it's really important for people to pay attention to this aspect of the tumor genesis and come up with simpler microenvironmental drugs. I wish companies won't do it because they can make money, so I was glad to hear Herb Epstein saying that they did it in a university rather than a company. The point is whether his company, how much he's going to charge from his company to have the drug. I meant to ask that, and then I thought, well, this is not the place. But I hope people, I hope people will hold him to the fact that that was public money and that government gave it to him. So the profit should be passed to the patients. Okay, as a side.
Okay,
Such
so
a troublemaker.
I think if there are no more questions, questions from the audience. I would like to thank the panel discussions for excellent talks.